Okay, it looks like it's recording. I see the red light at the top, so that's a positive sign.
Kent, just to let you know, this call has had up to 20 to 30 people at a time. Some people cannot speak in or they're on video, so they will text us. I'll be monitoring the chat and let you know if there's any questions. But it's pretty informal, and feel free to be conversational or just do your presentation. I know a lot of times I've heard you do an hour and a half to 2 hours on this topic, so you may be trying to cram in what's needed. But as I've told people, to me, this is one of the best presentations I've ever heard on management of suicide. Oftentimes what we do is we hear someone has thoughts of death and we send them right to the emergency room, and even mental health staff will often then set into doing a 90-minute evaluation and exploring everything. So I know even for me personally as a clinician, I have been really thrilled to hear your presentation, and I've spent a lot of time reading the books on suicide management and trying to be prepared. But this single presentation that you've done, even in the 1 hour and a half, was useful. Of course, the all-day conference that you've been able to do in Idaho has been amazing. So we're really happy for you to get to be here. We know it's going to be really useful.
Thanks so much. Appreciate those kind words, Patty. Well, you tell me when to dive in. I have some slides, but certainly I'm not going to discourage questions and comments. So I appreciate you running the chat box. There are multiple ways people can sort of interrupt and ask questions. So you just tell me when you're ready for me to dig in.
Okay.
Maybe we should give them another minute or two. It's 8 o'clock here in Arkansas, and with the time change, sometimes we have some stragglers.
Quarantine,
Yeah, looks like we have 10 people on the line, and what they're saying, Kent, is that Arkansas yesterday had the first case documented of someone with coronavirus down in Pine Bluff, and so our governor has, announced that we need to take precautions. And so there are school closings, and I know we've had some employees that are tried to come to work, but now their kids and they can't stay. So we may not have as many people as we normally have.
What?
No worries. I think we're having the same thing in Virginia. Our children is preparing to close for, I think, 3 weeks. And do distance-based learning for the next 3 weeks.
Wow.
Okay.
So before we get started, excuse me, I just wanted to ask if you can mute yourself, just because I think we're getting a little bit of background voices and noise, and that would be great. Just before we start, because we want to make sure that we could absolutely.
Where are you headed now?
I think we're still getting a little bit of background voices. I don't know if you could mute yourself, and then we'll start the presentation. Thank you. Okay, Kent.
Okay, I'll go ahead and dig in. Good morning, everyone. Thanks for connecting with us at the bright early hour of 8. If we have some late stragglers join us, that's no problem. You'll have to excuse me. I'm just getting over what I think is probably pneumonia. So if my voice gets a little bit hazy or fuzzy, please forgive me. I'll just drink some water and push through. We're going to be talking about managing suicide in primary care today. I've got probably too many slides, but the goal is to be able to ensure that we have both a meaningful discussion, but also that we hopefully give you some knowledge and tools that you didn't have before. So I'll just pause and ask, Kimberly, can you see my screen?
Yes, I can.
Perfect. Okay. So we'll go ahead and dig in. Just as a brief introduction, I'm a clinical psychologist I'm also a board certified behavior analyst. I was trained in suicide management almost 20 years ago when I was an active duty Air Force psychologist. And so since then, this has really been near and dear to my heart. It's my passion. So hopefully by the end of this talk, you will have at least learned one new thing and maybe even boosted your confidence a tiny bit with managing these sort of patients. So here's a select bibliography or set of references that I'll be working from. Let's start out at a high level. There are two recent studies showing that our ability to predict future suicides is generally poor. And so what that means is at a population level, when we take all of those data and then look at a single patient and try to say, is this person going to do it or not? We don't have the ability to do that. So that's sort of the bad news up front. Because our ability to predict is poor, it's not surprising that the rate just continues to go up. If you look at the left set of data from 1981 to 2016, there's the gender breakout, but also the total. You can see that the total suicides in the US climb from about 27,500 all the way to 45,000. And now I believe it's up to about 47,000 a year. The chart at the right shows the suicide rates compared to other public health and population health situations, conditions, things like accidents, diabetes, heart disease, all other sources of death, all causes. And uniquely, suicide just continues to climb. It's almost at a 45-degree angle there. So clearly, we haven't cracked the nut here. What I'm going to share with you is that some of the reasons why we haven't cracked the nut is because we're not using adequate tools and systems. So for example, the traditional suicide risk profile is a white male between the ages of 18 and 35 who owns a firearm. Well, we've known these facts for probably 50 years, but has that changed the suicide rate? That's a rhetorical question.
No.
Of course it is, right? Plus, do people who aren't white males, age 18 to 25, kill themselves? Do people of color kill themselves? Of course they do. Do people kill themselves in ways that don't involve firearm? Of course they do, right? So clearly, we've got to use a different system to understand this phenomenon because what we've used historically has not led us down a path of success. These are the 87 or so risk factors at the time this table was published that are related to suicide. We have no known way of devising an algorithm or formula to attach weight or validity to any of these or calculate the interaction of them on actual risk. So again, the traditional way that we have been trained to calculate risk, I'm suggesting, is not accurate. We all know that there are some common precipitants or antecedents to someone attempting suicide. 42% of people, it's relationship problem. 28%, there happens to be problematic substance use, job or financial problem in 16% of the cases, loss of housing in 4%, criminal or legal problem in 9%, a physical health problem is present in 22%. And in 29% of cases who attempt suicide, there's some sort of a crisis or a transition. I will repeat again, has knowing these data helped us prevent more suicides? The answer is no. We can't just profile and say, well, everyone with a relationship problem must be more heavily screened for suicide. That's impractical, certainly in primary care. I don't know about the people you work with, but a lot of us have relationship problems all the time, whether it's family or spouse or people at work. No one's perfect, right? So again, knowing these data have not gotten us to a convincing, compelling, effective set of answers for preventing suicide. In fact, I'm suggesting there's a more problematic cycle. When you look at the provider level, you have these are the green circles. You have some medical providers taking a better safe than sorry approach, some providers taking an accurate approach, and some providers taking a cavalier or pretty risky approach. Let's go through each one of them one by one. Those who take a cavalier approach either don't ask about suicide enough as often as they should, they increase their risk and liability and potentially violate ethics by not asking about suicide at least when indicated, if not more routinely, depending on, of course, the setting and what your professional license is. In these cases, if you follow the crooked dark blue arrow, the standard of care is not met and those clients who are seen are unsafe. Risk has not been mitigated. But if you look at those who take the better safe than sorry approach, maybe they do a crisis response plan, maybe they hospitalize the patient. When I do this in person, I ask for a show of hands, so I can't really do that in this format, but think about clients you've seen who have been psychiatrically hospitalized because of risk. Did they have a positive experience in the hospital? Are they eager to go back? Is it the first place they'll turn the next time they're feeling at risk or unsafe?
No.
Right, the answer is no. I would say that the vast majority of patients have a negative experience. And we can talk about why that is. That's sort of a whole separate conversation. But at the end of the day, if it's a really aversive experience, it punishes self-disclosure. And in the future, they're not going to disclose to you, the outpatient provider, that they're thinking of killing themselves. Now, we do know at the adolescent level, psychiatric hospitalization is slightly different. The programming is slightly different. So I'm generally talking about adults. So that's the better safe than sorry approach. And if you follow the red arrow, it leads back to more suicides. If we take an accurate approach to addressing risk, we are building this on mutual trust, empowering the client, following the standard of care, and giving the patient a positive experience, which reinforces future disclosure or leads them to be comfortable being honest in the future. This is what we're looking to disseminate with today's training. How do you accurately assess risk and make clinical decisions about the disposition? It's difficult, okay? But that's probably why people don't do it. Now, that's what's happening at the provider-patient level. At the system level, there's an even more problematic cycle. So at the right here, you see the same cycle that we just had. That now becomes one component in a bigger systemic cycle. Let's start at the bottom. Outpatient mental health providers have, their skills are declining, okay? Let's start there. If their skills are declining or their skills are not sharp, then if you follow that arrow up, this pattern of either better safe than sorry or cavalier assessment and management of risk is happening. Follow the blue arrow to the left, that leads to no change in suicide trends. There are no change in suicide trends. We have more psychiatric hospitalizations opening. People saying, suicide's not changing. We need the most safe option for treatment, which of course is psych hospitalization. Well, if we're just hospitalizing people, fewer people are receiving help upstream, which means in primary care, especially, and also in the outpatient behavioral health realm. And then, of course, if they're not, like any disease, let's look at COVID-19. If we don't do early identification and testing, more people wind up with the disease, right? Same with suicide. If we're not working upstream and helping people earlier, the overall risk level of the population rises. And so in the middle here, you see the schematic of the suicide trend rising against other causes of death. So this is an even more problematic cycle where the providers' poor clinical behaviors are sort of maintained by the system's problems handling these patients. And here's just a slide to show that there's evidence that this is happening. From January of 2008 to July of 2015, the number of pediatric hospitalizations for SI is increased. It's increasing, and if you look the curves, the distance between the crests and the troughs are increasing. Within the within behavior analysis, what we'd say is the variability is increasing, which means when variability increases, we have less control over that variable, that phenomena. So what it means is if the percentage of overall encounters with suicidal ideation is increasing, we are getting worse at managing that phenomenon. So there's already some evidence that we have, and this is just one piece, that shows that these hospitalizations are increasing. Let's talk for a moment about the limits to psychiatric hospitalization. Many of us sort of feel relieved when we know a patient is going to the hospital, but the reality is it's not a gold standard. There are no robust scientific studies I have ever read, and certainly I'm not omniscient, so they might be out there, but there are no robust studies showing that psychiatric hospitalization treats suicidal symptoms. What it does is it ensures safety for a finite period of time when the patients are hospitalized. Well, that's wonderful, but what happens when the patient needs to leave? We know they can't live in the hospital, and we know that most hospitals stick to a 48 to maybe 72-hour window where they'll hold on to a patient. Well, this explains why the post-discharge suicide rate is approximately 100 times the global suicide rate during the first 3 months after discharge. It also explains why patients admitted with SI or suicidal behaviors have rates near 200 times the global rate when they're discharged. So if the inpatient community is not creating programs that treat patients, but rather they're just ensuring safety, and the risk of attempting actually climbs upon discharge, whose responsibility is it to truly manage these patients in the most evidence-based way that we know of? That's a question. Either unmute your phone and shout it out or type it into the chat box. Who is responsible for managing this community in the most evidence-based way if the inpatient community is not doing it? And I don't say that in a negative way. It's just that that's not the type of program they run.
Kent, this is Patty, and that you really are talking about the standard of care, especially in primary care. I mean, we consider, and people are often afraid to do depression screens because they're afraid of question number 9 when people have thoughts of death, and then they know that they need to do something about it, and that's overwhelming in primary care.
Absolutely. Absolutely. So U44051 said ambulatory care, PCP. Alan Meese said outpatient care. That's exactly right. It's the outpatient community that has to take responsibility for this. And largely we do already, right? We'll get to some data in a moment. Clearly this is a miscalculation. I think this is often the knee-jerk reaction of legislators, administrators, people who are really just looking to fix the problem, or quite frankly, people who have special interests in building a certain business model. Here's the spectrum of suicide prevention actions we do. The ones I've highlighted are the ones we tend to do best. We give people the crisis line, so care linkages and transitions. We give people the crisis line. We try to screen, or maybe we ask, that's great. We also, what's very common is gatekeeper programs, which is that old idea that if you see something, say something, right? If, Patty, am I screaming? I feel like I'm yelling. Okay.
Oh, you're doing well, doing well.
Can you hear me okay?
Yeah, absolutely.
I realized I'm projecting my voice as if I'm in a lecture hall. So we have many gatekeeper programs too that, of course, it's if you see something, say something. So if you see a friend struggling, a family member struggling, try to get them to help. And those, again, those programs make great sense. And then we have responding to crisis, which is a related concept, but it also involves certainly first responders, crisis lines, EMS, et cetera. What we're particularly bad at is the orange one, which is teaching people how to get help and teaching people that there's, while decreasing stigma around suicide so that people feel more comfortable. I will tell you that addressing suicide in primary care helps to decrease stigma and increase people's help-seeking behavior. Right below that in navy blue, we're also particularly bad at postvention. Postvention is the component of after a suicide in a community. How do you help the community recover and heal and get closure while also stemming any kind of contagion that might arise? Just to the right, reducing access to means. There's recent studies coming that are in press right now, coming out of the South, to be honest, that show that if we reduce access to firearms, we actually decrease suicides by 50%. That's 50. Okay, those are compelling data. Now we can talk later about how we can decrease suicides by 50% or suicide attempts by firearm control, but be careful, this is not a political discussion, okay? It's a scientific one. If you move over to the right, life skills and resilience, that's the red square. We're also particularly bad at doing that. We're really good at hospitalizing people when it's way at the moment of crisis, but really bad at working upstream and sort of bolstering their ability to cope. Again, that's what we're going to talk about today. Go straight up where it's green, it says effective care and treatment. We're pretty bad at that, and we'll talk about some research that demonstrates that in a moment. And then the last component of a comprehensive approach to suicide prevention, according to the Suicide Prevention Resource Center, is connectedness. We are becoming a less and less connected world. In some ways, social media and the internet, platforms like Zoom, will bring us together, right? But at the same time, people are very much in their own lanes trying to do what they're doing. We're quite an individualistic society and becoming even more so. So here's the problem. We have inadequate training. Dermatology, endocrinology, orthopedics, cardiology, pulmonology, ER, you name it. They all look to who to address suicidal patients. What specialty they look to? Psychiatry, psychology, social work, counseling. They look to the behavioral health field. And here's the kicker. While they look to us to manage it, studies have shown that less than half behavioral health professionals receive formal training in suicide risk management in graduate school. And when they do, the total training time on average is under 2 hours. Could you imagine if cardiologists only got 2 hours of training doing a cardiac catheterization? Or a brain surgeon only got 2 hours of training doing some sort of brain surgery? So this is the most severe fatal condition within the mental health field, and yet only half of us are trained, and the average duration is about 2 hours. That's concerning. There's another study that came out last year, specifically for psychologists, showing that they're less willing to work with clients who are experiencing suicidality compared to clients who aren't. And their reluctance to provide services, they had greater concerns about the adequacy of their suicide-related skills and training, and that there were fewer resources in the community that they could use to assist them. Again, if I could see your hands and you were raising them, I'd ask, is anyone surprised to hear this? I mean, if you reflect on your own training, think about how many courses, classes, workshops you had in suicide management. It's one of those things that we take because we have to, or because it's ethics, or few of us are eager to treat high-risk patients who we know there's a percentage who are going to die, right? And so what's the problem with inadequate training? The problem is we are less equipped to deal with these patients when they come in. A second problem is we don't see these patients every day. So if you only do something once a week or once a month, how proficient are you in that skill, right? So that's sort of part of this cycle, isn't it? Okay, so if we're working in primary care, what's the likelihood we're going to run into one of these patients? Well, prevalence rate for suicidal ideation and behaviors in general medical settings is 2 to 5%, but it remains one of the top 10 causes of death among adults in America. For children and adolescents, ages 10 to 18, it's the #2 cause of death. If you're working in an integrated primary care setting, which means you have behavioral health in-house, the prevalence is likely to be around 12%. But what the studies show is that it's only if you ask. Now note that patients don't typically disclose if we don't ask. Suicidal patients, however, report poorer health and they visit the medical provider more often when they're suicidal. So they're reporting greater levels of bodily pain, lower energy, more physical limitations, and we know that their medical visits increase in frequency in the weeks preceding their death by suicide, up to 3 visits per month. So could you potentially look at all patients in your system who have 3 visits per month all of a sudden compared to their baseline and screen them for suicide? That would be a very wise and efficient way to try to proactively manage this problem. You could also do routine screening. Now, this is tough because the U.S. Preventive Services Task Force did a study in 2013 and concluded that they can neither confirm nor deny the benefits for routine screening. In other words, there's not enough evidence to say that it's worth it, and there's no it's not worth it. So that means it's up to your judgment as to what you want to do about it. Note that asking the PHQ-9 alone is not sufficient, and we'll talk about why in a moment. So it's estimated that between 1 in 10 of primary care patients experience suicidal symptoms at any given time. So this is sort of like the lifetime prevalence, right? And of those who die by suicide, 45 visited their PCP within the month, 20% visited their PCP within 24 hours. So does that mean that PCP appointments drive people to kill themselves? Probably not. That's a joke. Maybe it's a little too early for dry humor. No, what it means is that this is a wonderful opportunity. It's a window of opportunity for us to catch these patients. Particularly if you have geriatric patients. 73% of the elderly who die by suicide visited their PCP within 1 month. So if we truly want to catch these people before they do something, primary care is the ideal place to do it because about 90% of people with health care go to their PCP at least once a year. And let me go back. What might you imagine? This is the audience participation part. So use the chat box. What might you imagine are the chief complaints? For people who die by suicide, 45% visited their PCP within 1 month. For that last appointment when they were living, why do you think they came into the primary care provider? Jot your answer down in the box, chat box. Okay, someone has said pain. I'll give you a moment to, and if you're just calling in by phone, feel free to unmute and just shout out what you think a chief complaint might be for patients who were suicidal and died within a month by suicide. Pain, not feeling well. Okay, good. Those are good guesses. So what we know is that anxiety and depression are 2 out of the 5 most common chief complaints in that last appointment. But then we have unspecified GI symptoms, unexplained cardiac symptoms, and hypertension. Now, hypertension is probably just because of its high prevalence, and it's probably related to how it's related to stress. But for unexplained cardiac symptoms and unexplained GI symptoms, we would never ask these patients if they're thinking of killing themselves. So if we take a traditional approach to suicide screening, which is in primary care, as indicated, for those who aren't on video, I'm using air quotes, as indicated, we would miss 60% of those who are suicidal and who are going to leave that appointment and kill themselves. So it just makes sense to ask, can you think of another fatal illness that can be mitigated as quickly as by asking one question and as inexpensively as by asking one question? Right? Think about an MI, think about all sorts of acute fatal conditions. pancreatic cancer. There's no other fatal condition other than suicide that you can mitigate so quickly and cheaply, because it only requires a few minutes and a few questions. So from my perspective, in contrast to the United States Preventative Services Task Force, I think the juice is well worth the squeeze. Okay, so let's pan back for a minute at the 10,000-foot view. There's something called the fluid vulnerability theory. This is how I'd encourage you to frame suicide in your mind. We all have a baseline or set point risk for suicide. This is comprised of static risk factors, right? The idea that you're a 25-year-old white male, the idea that you're maybe a parent died by suicide. And then we also have acute risk factors. So these are those precipitating incidents or life events that may drive up our momentary risk for suicide. So this is no different than how we look at cancer. This is no different than how we look at lots of diseases, heart disease, right? Do you have a genetic vulnerability? Do you have a biological component? Does it run in your family? And then, what's your race? Are you black? Are you white? Are you Latino or mixed race, biracial, right? And then we look at what's happening acutely. Did you just get a divorce? Are you in legal trouble, right? So suicide's no different. If we think of it like any other public health or medical problem, it really helps us approach it in a methodical way. Now, there are all sorts of people. The more in primary care, the more likely, if we're running a patient-centered medical home model, then we're going to have a whole host of people, some of whom are not even on this slide. So we may have embedded physical therapy, we may have an acupuncturist, we may have chiropractor, we may have a clinical pharmacist, we may have social work, we may have a therapist, we may have psychiatry, all sorts of people now who are sort of being integrated into the medical home. I've kept with a fairly basic team here. It's CP, nurse, medical assistant, and then a behavioral provider who's integrated, and then maybe a mental health provider who's working external to the clinic. And these are the roles that generally people will play. Your PCP is going to identify these patients, refer, hopefully by a warm handoff, to an integrated behavioral health provider or a specially trained nurse. And the PCP is also going to manage medication. Nurses are going to identify, refer, coordinate care, and communicate. They also might do some of the assessment with the PCP's eyes on. Medical assistants help identify, refer, maybe they screen, but they also coordinate care and communicate back to the rest of the team. Your behavioral health person who's integrated or behavioral health professional identifies, but they're also doing the risk assessment and trying to reduce the risk and determine the disposition. They're making recommendations to the nurse and PCP, and if, depending on the type of integrated model they're running, they may or may not provide treatment. Without going down a rabbit hole, if they're providing behavioral health consultation, primary care behavioral health, they're not going to provide treatment. They're going to refer that patient to a therapist who can provide treatment. If you're running a co-located mental health model where they're essentially providing a full range of psychological services within primary care, then they may provide the treatment right there. And of course, your external mental health provider provides treatment and continually assesses risk, provides consultation liaison services to other members of the patient's healthcare team. These are from an article we published in Clinical Psychology Research and Practice in 2014. So these are just a little bit of a deep dive on their specific roles. We're not going to go into this in much detail. Don't want to repeat myself. So there's something called the suicide mode. This is one of the handful of things that I hope you take away from this talk. We all have predispositions up here on the left side, right? Prior suicide attempts, abuse history, impulsivity, genetic vulnerabilities. I heard earlier this week they have found some biomarkers for suicide related to it's EEG biomarkers, actually, which is fascinating. My guess is it relates to impulsivity. But so just this week, a study was published in Psychiatric journal. Can't remember which one it was. Psychiatry Online, I think it is. finding biomarkers for EEG. So clearly there are some predispositions here. Then we have triggers. We know what these are, right, guys? Job loss, relationship problems, financial stress, life transitions. But that leads to this suicide mode, which is a constellation of clinical sequelae. So it's cognitions, things like I'm a terrible person, I'm a burden to others, I can never be forgiven, I can't take this anymore, things will never get better, there's no way out. And the emotions that correspond to those thoughts, which are depression, desperation, guilt, shame, anger, anxiety. And then, of course, behaviors that correspond to those thoughts and emotions, which social withdrawal, sometimes non-suicidal self-injury, rehearsal behaviors, substance abuse. And then there are physiological factors that, of course, coincide, like agitation, problems with sleep, concentration difficulties, forgetfulness, indecisiveness, physical pain, or other somatic symptoms. It's so important to be able to identify when someone is in the suicidal mode or has the suicidal mode turned on. Suicide is a state of hopelessness, burdensomeness, powerlessness, and what some would call, what Thomas Joyner calls thwarted belongingness, which means you so desperately want to be a part of something, but you cannot, whether you are being kept out or just you're not able to do it. If someone is feeling powerless, what's the last thing you want to do to them?
Put them in a locked unit.
Put them in a locked unit, right. Thank you, Patty. So if someone's feeling powerless and hopeless, to put them in a padded room or a locked unit or a sterile room, take away their shoelaces, take away their belt, take away everything that makes them feel like a whole person. I would suggest that that's part of why psychiatric hospitalization is not effective in managing suicide and why it increases risk. The other thing as an outpatient provider that you don't want to do is talk the patient out of killing himself or killing herself. We do this in very subtle ways that we often don't realize. So I'm going to just list a few ways that this sounds. But first, I'm going to ask you, what do you think it sounds like in your words? Type it into the chat box or unmute your phone and just yell it out. What do you think it might sound like if you are trying to talk the patient out of killing himself or killing herself? Because if you know what it sounds like, you can observe yourself and stop yourself from doing it. If you don't even know what it sounds like in your own words, you won't stop doing it. In fact, you won't realize you're doing it. So what does it sound like? What kinds of phrases do you hear yourself say or other people say when they're trying to talk a patient out of killing himself?
Oh, it's not that bad.
Good, thank you. So, oh, it's not that bad, or oh, it'll get better, right? What else? I see in the chat box, there are positive things to focus on, sure. Or, oh, this is only temporary, nothing lasts forever, right? Something like that, or it'll get better. What else, guys? Come on. How about, what would your mom say? What would what would your kids do? Right? All of these bringing other people, what are we going to do? Guilt someone into not killing themselves? I think that's worse. Now we've added guilt onto their burdensomeness and powerlessness. Oh my goodness. So just be aware, increase your attention to your own words when you're with these patients. Our inclination is, of course, to talk them out of it. Of course, our instinct is to stop someone from harming themselves. But the reality is, if you're talking them out of it, you're alienating them and potentially making them feel more powerless. And so this is not a sustainable way, even if this works today with the patient. What happens the next time they're suicidal and you don't work there anymore or you're sick? So you can't predicate suicidal risk management on your relationship. That's not sustainable. It's not generalizable. It's not scalable. And I would argue it's not effective. The second there's a breach in your relationship, you're going to expect a bump in the suicide risk. So instead of talking them out of it, what we want to do is help patients learn how to cope. We know that a stronger sense of meaning in life is significantly associated with lower emotional distress. We know that if we do effective crisis response planning, it reduces suicide attempts up to 76%. We know that brief CBT for suicide, which is a very specific manualized treatment, reduces suicidal behavior by 60% compared to treatment as usual. Now, brief CBT for suicide is not a treatment you're going to do in primary care, but effective crisis response planning is something you will do in primary care as a PCP, as a nurse. And if you have an integrated behavioral health provider, that's the ideal person to take this patient off your hands and do the crisis response plan. This is a brief schematic. I will forward it to Dr. Gibson and she can disseminate to you all. This is a brief flow chart of the evidence-based way to manage suicidal patients in primary care. And we're going to go through these steps very quickly, but that's why I'm giving you this schematic, this flow chart, so that you can take this with you and hopefully post it at your desk or at your computer in your clinic. This is from the Journal of Professional Psychology Research and Practice. Uh-oh, what did I just do? That's what I want to do. Okay, so skill one. Skill one is to differentiate between suicidal ideation and non-suicidal ideation. This is, if you don't take anything else away from this talk this morning, except for don't talk patients out of killing themselves, this should be the second most important thing, because this is where the conversation starts with patients. Sometimes patients say, I wish I were dead. I wish I could fall asleep and never wake up. Or I just wish I weren't here anymore. None of those statements constitute suicidal ideation. Those are what's called death ideation, or non-suicidal ideation, or non-lethal morbid ideation. Thoughts of death, which is the second one, right, non-suicidal ideation, those don't reliably result in suicidal behavior. Suicidal ideation, what makes them suicidal ideation different is that the person is thinking of death or dying, and she sees herself playing a role in making that happen. That's the distinguishing feature. The most important thing you can do when you hear a patient talking about this is to distinguish. Are you just thinking of death and dying and you wish you weren't here? Or do you actually foresee yourself enacting your own death, playing a role in your own death, facilitating your own death? That is, again, one of the most important things you can do. A few minutes ago, we talked about how the PHQ-9 alone is not going to help screen for suicide. Can anyone answer why that is, now that we've viewed this slide?
It doesn't distinguish between death ideation and suicidal ideation.
Yes, Dr. Gibson's dead on, exactly. So it actually screens more for death ideation. So what that means is you're going to get a lot of false positives if that's what you're using to routinely screen for suicide. Now, some people are okay with that. They'd rather be safe than sorry from a screening perspective, and maybe they have the manpower, or they don't. They're just willing to take the risk, but they're willing to do that. If that's the case, what I would encourage you to do is use the PHQ-2 plus question number 9 routinely for every patient. Anyone who endorses question number 9, the follow-up questions have to differentiate between actual suicidal thoughts versus death ideation. That is probably the most low maintenance way to do routine suicide screening, the PHQ-2 plus question number 9. And then again, any positives, you have to follow it up and distinguish which one of those patients who are thinking of death are also thinking of enacting their death. Okay? Here are some sample questions. Some of these are embedded within that flow chart that I'm going to send to Dr. Gibson, so we're not going to go through them. That's skill number 1, critical skill. Skill number 2, assess for past suicidal behaviors and multiple attempt history. When we look at all the risk factors driving suicide, when people have past suicidal behaviors or multiple attempts, whether they have substance abuse or not, whether they have a history of abuse or not, whether their mother died by suicide or not, regardless of the risk factors, this one is the most robust predictor of future suicidal behavior. Now, how do we define multiple attempts? That is 2 or more suicide attempts. The research actually shows that people who attempt once, the vast majority never attempt again. But among people who have had 2 or more attempts, this is a different group of people, okay? They are at a chronic, moderate risk for suicide. Because remember, suicidal thoughts, these are an escape-oriented thought. The idea is to escape one's pain. And so in fact, it's part of our problem-solving repertoire. It's just that it's not a good choice, obviously, right? So when we look at the research and we break down multiple attempters, that means 2 or more, single attempters, and people who are just thinking about it but have never attempted, they have very different risk profiles. Those who are just thinking about it, they start lower and their risk elevates, but not higher than the others. Likewise, the single attempter starts a bit higher and escalates, but not higher than multiple. And the multiple attempters, so again, that's 2 or more prior attempts, they start higher and they end higher. So we're talking about fundamentally different groups of people here. Now with the multiple attempters, some people say, oh, 2 or more attempts, what constitutes an attempt? Okay, let's talk about that very briefly. An attempt has to involve a self-inflicted action, something I chose to do, whether it's active or passive, it doesn't matter. So whether I let go of the steering wheel and whatever happens to my car happens, or I pick up a gun and I put it to my head, it doesn't matter if it's an active or passive behavior, it's a decision I made. And when I made that decision, I either imagined, anticipated, hoped I would die, or the thought came to mind that I could die, or I calculated that I could die. Anything in that realm makes it a suicide attempt. Whether I got injured or not is completely irrelevant. So someone's injury does not make it an attempt or non-attempt. That's completely irrelevant. It's what was the person thinking when they did this potentially self-injurious action. And it does, again, it doesn't even have to be hoping to die. If you conceive that this action could possibly kill you, it is considered an attempt. If someone interrupts you, it's in the middle of it, it's still an attempt. Just want to make sure we're clear on that. That's really important. Okay, and now let's look at these data slightly differently. The multiple attempter versus a zero attempter. You can see that the zero attempter, the risk, baseline risk is low. Remember fluid vulnerability theory, the baseline risk is low. This dotted line is the acute crisis. When an acute crisis happens, the person escalates quite rapidly, but as you notice in the curve, they also resolve quite rapidly back to baseline. Your multiple attempters are at a much higher baseline risk, and when they escalate, it's almost exponential, and look how much longer it takes them to resolve. It's not even clear whether they resolve to baseline or not. So these are people who are constantly returning to the solution of killing themselves to manage their distress. They haven't yet concluded that that's not an effective strategy, or that that's not the strategy for them, or they have not yet built a repertoire of coping skills to use instead. Is there a question? I hear some voices. Is there a question from one of the listeners? Okay, great, we'll move on. So objective indicators of risk are better predictors than subjective indicators for our multiple attempters. People who are multiple attempters are not good at predicting their own escalation and risk. These are the patients who will sit in your exam room and say, oh, I've had 5 suicidal attempts, but I'm feeling fine today. And then on the way home, they'll get into a fight with their spouse and try to kill themselves. So it's because they escalate so quickly and they're so poor at assessing their own risk and their levels of distress are much more erratic. So objective indicators of risk of things like, do they have the means to kill themselves? Do they have a firearm? Do they have drugs? Do they have over-the-counter meds? And also, is someone likely to find them? Do they live 10 miles off the main road? Do they live alone? Is their typical routine to hang around their house all day and talk to no one and have no one come by their house? If that's the case, they're at higher risk if they've had 2 or more attempts because they're unlikely to be interrupted, unlikely to be distracted. For these folks, their survival reaction also serves as an indirect indicator of intent and risk. So if someone wakes up from a suicide attempt in the hospital and says, "Oh, thank God I'm alive," that person's unlikely to attempt again. If the person wakes up in the hospital bed and says, "See how much of a failure I am? I couldn't even kill myself," that's someone who's probably going to attempt again. So, excuse me. So if your patient does have even one prior attempt, it's helpful to ask the patient, what did you think and feel the second you realized that the suicide attempt did not work or that you were alive? And someone's worst point in a suicidal episode is a better predictor than other episodes. When we say worst point, what we mean is the lethality of their means. So did they use a firearm or did they take 5 Tylenol? If someone had 10 attempts, we don't need to assess every attempt. We should probably assess the most recent attempt and then the worst point. The worst point is not how injured they got, because remember, that's circumstantial, that's coincidental, but rather what was the most lethal means that they used. Okay, here are some sample questions. Again, we're not going to go into it at length. Skill number 3, this is where you assess a current suicidal episode. Most of us in everyday practice start here versus the first 2 skills. We think of ideation, plan, and intent. Well, it's really not that simple, okay? So let's talk about this. On the right side is suicidal desire and ideation. In factor analysis studies, what it shows is that suicidal desire and ideation actually are somewhat predictive of suicidal behaviors, but they're not the strongest predictors. So they're weighted lower than all of the things on the left. Resolved plans and preparation, like sense of courage, availability of the means to kill oneself, the opportunity to kill oneself, specificity of one's plan, the duration of suicidal ideation, the intensity of those thoughts, those are better predictors or weighted more heavily as risk factors for subsequent suicidal behavior. So for example, and by the way, at the bottom, it gives you sort of a algorithm of how to judge mild, moderate, or severe extreme risk. You should know that our research is poor on stratifying risk into categories of mild, moderate, severe. So this is just a suggestion based on the evidence. If someone has 1 or more factors from the left, 1 or more resolved plans or preparation, they're automatically at a moderate risk because these are such robust predictors of subsequent suicidal behavior. Whereas if they had 2 factors from suicidal desire and ideation, they'd only be at mild risk. So consider that the stuff on the right, if someone, like for example, someone wishes to die, if they really want to die, that doesn't mean they're at high risk or even moderate risk, okay? But if they have the opportunity, meaning they have no one's going to interrupt them, distract them, or catch them in the act, they have a firearm, and they have the courage that they can kill themselves, that's vastly higher risk. On the idea of duration of suicidal ideation, what you should ask every patient when assessing the current suicidal episode is, how many times a day are you thinking of ending your life? And how long are you thinking about that on average? What's the duration? If someone's thinking about that for 5 hours every day, that's really concerning. That's very high risk. And we also want to know, why is it only lasting 5 hours? How come not 6 or 7? So what interrupts them? Is it that they have the capacity to shut those thoughts off and shift gears and do something else? Or is it that it only gets interrupted by external demands or external events like kids, grandkids, significant other, friends, neighbors. So that's really important to understanding their risk. Okay, then we have to look at intent, which is a really squirrely thing to try to assess. We already talked about objective versus subjective indicators of intent, so we're not going to review that. But intent, I would discourage you from asking your patients if they intend to kill themselves. That is a very loaded question. What we know about suicide is it is a state of ambivalence. As a state of ambivalence, that means we have reasons to end our lives and reasons not to end our lives. So we're going to pick up on that in a minute. While you're assessing the current suicidal episode, you also have to assess their access to lethal means. Remember that restricting access to firearms or delaying access to firearms decreases suicidal attempts by 50%. So someone's intent actually has a weak relationship with lethality. So if someone really, really, really wants to die, that doesn't mean she'll use a firearm. And if someone kind of wants to die, that doesn't mean they'll take a few Tylenol. It's all about what's available to the patient. That's what predicts the likely lethality of their attempt. And most patients underestimate the lethality of what they're doing. So when we talk to people who have tried to kill themselves with a firearm, and we ask them, okay, how long did it take between choosing to end your life and picking up the gun? How long was that? 24% of people say they made the decision to act in 5 minutes. 70% say they made the decision to act within 60 minutes. So there is a strong link here between just access and likelihood of doing it. I'm noticing the time, we have about 8 minutes left, so I'm going to try to fly through this. Means restriction is effective specific to the method. So for example, if we do means restriction counseling, which usually your behavioral health consultant is going to do, or someone else in the clinic, you could have a nurse do it. Usually PCPs don't have enough time. But following a suicide attempt, when we talk to people about delaying access, restricting access, making it more difficult for them to access that item or that substance they used to attempt, when we talk to them about that, we know that higher rates of people will actually comply or adhere, and therefore we have lower suicide rates. Okay, so suicide's a state of ambivalence, as we said before, but what you should know is that most people who are thinking about killing themselves don't truly want to die. They just don't want to live feeling all the stuff they're living with. And so we have to ask them, is that how you feel? The people who are not ambivalent about living and dying are frankly already dead. So they are so determined to die that they're going to kill themselves. They're never going to raise a flag. They're not going to come into the clinic. If they do come into the clinic, they're either going to deny having suicidal thoughts, or they're going to say something like, well, yes, eventually I'm going to kill myself. I'm just not sure when. Someday I'm going to wake up and I'm going to know that, you know what, this is the right day. But we're not going to hospitalize those patients anyway because it's not acute enough. So the 99% of the people you're going to see in clinic are ambivalent. The fact that they came into the clinic is empirical evidence of their ambivalence. If you come into the clinic and you report suicidal ideation, that's something that is driving living and help seeking, and something that is stating a desire to die. So that is evidence of the ambivalence. So because patients, when they're thinking about suicide, they believe things like I'm going crazy, or I'm going to lose control of myself, I'm becoming someone different, I'm not who I thought I was. Don't let them buy into any of these beliefs. Instead, teach them that suicide is a state of ambivalence. Give them that reframe to understand themselves. If people believe they're going crazy or losing control, they're likely to do things that are uncharacteristic of themselves. So we need to ask them, so talking about ambivalence is both a way to determine if they intend to die, and it's also a way to help them not do things out of character. So Mrs. Jones, I heard you say before that you were thinking of killing yourself. Is it that you truly want to die and you have nothing to live for, or you just don't want to live if you have to live with all of this pain? and you want to find out which it is. If they say, oh, I don't really want to die, if this pain could go away, I would love to live, then what you're concluding is this patient's ambivalent. That's fine. That is the nature of suicide. So explicitly talk to them about ambivalence. Then lastly, it's a segue to talking about their reason. Actually, this is not last. Just kidding. This is number 4. There's a number 5. This is talking to them about reasons for living. So when they say, I don't really want to die, I just don't want to live this way, then you ask them, well, if you didn't feel all this pain, what would you want to live for? What would you be doing with your life? And here are several other questions. What's keeping you alive right now? Take all the pain away. What's the most important thing to you in life? So it is critical that we talk about reasons for living. And lastly, we use a crisis response plan. So this has to be tailored to the patient. This is not an administrative tool. This is as much an intervention as anything else. This is giving them a way to cope that is very realistic and doable and tailored to who they are. So can you recognize your warning signs? When their suicide mode turns on, what are their exact thoughts and feelings and physical symptoms and behaviors? They have to be able to self-identify those if they're going to take out this crisis response plan and use it. You can write this on a piece of paper, or they can put it in their smartphone. Then we have self-management skills. The critical piece that makes this reduce suicide attempts up to 76% is making sure you discuss their reasons for living and making sure that as part of their plan, they engage their reasons for living. Then we have social support, and finally, crisis services like 911, going to the ER. Here's a quick checklist of ways to remember all of this stuff. And I can forward these slides to Dr. Gibson. Here's a quick documentation. Notice we didn't talk a lot about protective factors. That's because the research says that protective factors are not good predictors of suicide. They're actually helpful for treatment planning, but they're not good predictors of risk. If someone has 20 protective factors and 2 risk factors, that doesn't mean they're at low risk for suicide. So the things in red are what I would encourage you to document. The things in yellow are what traditionally we're told to document. If you have to document them within your system to satisfy requirements, that's fine. But just know that the items in red are the real meat and potatoes of your risk assessment and what's going to actually drive your decision making. Fine, here's a book I recommend, Managing Suicide in Primary Care by Bryan and Rudd. I don't get any, I have no conflicts of interest. I get no royalties or kickbacks. It is just the only book I know of that addresses this and addresses it in the most cogent manner. And here's my email address. If you have questions about this presentation or you think I can be helpful in your system, please give me an email, send me an email. Happy to answer questions now. And of course, I'm happy to answer questions over email.
Dr. Corso, thank you so much for this amazing presentation. As I listened to the presentation and we realize we really do have a lack of training in this area. However, it's critical, especially I think as we're trying to manage patients in primary care and we're looking at some of the issues. Suicide is definitely an issue. And so as I'm hearing this, my hope is that we have an opportunity at some point to bring you to Arkansas so we can have a more in-depth training on some of the skills that are necessary. So we appreciate you taking the time to speak to us. Does anyone have any last questions or comments about today's presentation?
I would just echo, there's been some comments that this was an excellent presentation and very helpful. And again, to me personally, it reminds me how good information that's very practical.
Well, you're welcome. Happy to help. All right, if there are no questions.
Thank you so much.
Take care. Have a good week, guys.
You too.
Take care.
We appreciate it. Bye-bye.
Thanks, everybody.
Thank you all.
Hey, Kim, I'll give you a call on the phone.
Sounds good.
Take care. Have a great day, everybody.
Thank you. I'm gonna hit the record button.